Welcome to GEMcast, the Geriatric Emergency Medicine podcast, where we discuss important topics in the care of older patients in the emergency department. I'm your host, Christina Shenvi. GEMcast is produced with the Geriatric ED Collaborative. You can find more episodes on any podcasting app, and you can find the show notes on the resources page of gedcollaborative.com. Hello, and welcome back to today's episode of GEMcast, where we are going to dive into a new topic that we haven't exactly covered before. I'm Christina Shenvi, and my guest today is Dr. Martin Casey, who is an expert in deprescribing. So thanks for being here, Martin.
Yeah, thank you, Dr. Shenvi, for having me. It's great to be here.
So today we'll be discussing deprescribing in the emergency department, a topic that's gaining a lot more attention in our field. And in fact, just very recently, on August 1st, 2024, CMS approved the new age-friendly hospital measures, which are going to be things that hospitals are required to report on as to whether they do these activities. And it consists of 5 different domains, and there's going to be lots of coverage on this on GEMcast coming up. But domain 2 is specifically relevant to deprescribing. And just to give you an overview of what it is, in this domain, hospitals will have to attest that they review medications for the purposes of identifying potentially inappropriate medications, the acronym there is PIMS, for older adults, as defined by standard criteria, guidelines, etc., and that they have to review this on admission, before major procedures, and on significant changes in clinical status. And then once identified, PIMS should be considered for discontinuation or dose adjustment. So that is exactly what we're talking about here today. So thanks for being on GEMcast. Let's go over what is it that you think are the key things that are important to know about deprescribing in the ED.
Before we get started, I think let's develop a shared mental model and just define deprescribing. From there, I think it'd be important just to discuss barriers to deprescribing in the emergency department that are unique to our job, and then just work through some specific ED cases in which deprescribing might be appropriate.
That sounds perfect. So let's just start with defining deprescribing. What exactly does that mean?
So this definition comes from the U.S. Deprescribing Research Network. Deprescribing involves identifying and reducing or stopping medications that may no longer be necessary or might be causing harm in alignment with a patient's preference. So there's a lot there. I just want to emphasize this is a multi-step process, and it also includes dose reduction or even substitution with a less harmful medication. Such approaches are particularly friendly to ED physicians who have little to no familiarity with their patients and want to make smaller adjustments to medication regimens.
That's very true. As ED docs, we don't always know what the patients are on long term. And most importantly for me, I don't know what's already been tried necessarily. So if a patient comes in and I think, this medication may not be necessary, I don't necessarily want to stop it. There's a saying by G.K. Chesterton that I don't have it exactly in front of me, so I'm paraphrasing potentially, but he says, never move a fence post unless you know why it was put up. So you want to know before you take away this medication, well, what is it there for? What alternatives have they tried and maybe failed, or what happens when they're not on it? And hopefully their primary care physician knows that, but in the ED we don't. So it makes it a little harder.
This is a fantastic point. And it generally reflects the opinions of most practicing ED physicians who don't want to get involved in what they deem to be an outpatient issue. That being said, I just want to emphasize deprescribing is a multi-step process. It all starts with identifying problematic drugs. And this is core to what we do. The emergency room sees over 1.5 million patients with adverse drug events in the U.S. every year, according to the CDC, and this is likely an underestimate. And such events occur disproportionately in the older adults. When you go to the literature, both experts and patients agree that the manifestation of an adverse drug event is the most important reason to discuss and consider deprescribing.
So the challenge, though, is that it still doesn't address the ED doc's concerns about stopping or altering the dose on a medication that another physician started. And the concern that what if there's key information that that prescriber had that we as the ED doc don't? How do you approach that?
So this is probably the toughest part of deprescribing. I don't mean to imply that we should make these changes without consulting the prescriber and considering their opinion or any information available to them. Rather, I'd argue that it is our job to diagnose adverse drug events, explicitly pointing out to patients these problematic medications and building bridges back to the outpatient prescribers. Such bridges can come in multiple forms to outpatient prescribers. This can be as simple as sending an EPIC message or doing patient education at the point of care, or making smaller changes to medication regimens, such as dose reduction or medication substitutions, like I mentioned. Regardless, this process is challenging, and I think there's much research needed to be done to figure out how this is best done in the ED setting.
When I think about times when I've told a patient I'm concerned about a medication that you're taking, usually the conversation goes that I first talk to them about their medications, find out if there's a new medication. Did they come in with dizziness and they were just started on tamsulosin for a kidney stone last week, and it seems like those two are connected? Then I'll talk to them and say, well, here's what you're taking it for. Do you still have a kidney stone? Do you still need to be taking the tamsulosin? If not, let's stop. Maybe that's what's causing your dizziness. Or I'll say, hey, I'm concerned about this medication. Can you set up an appointment with your doctor, or do you have an upcoming appointment with your doctor? Can you bring it up with them? Depending on, what their capabilities are and understanding of their healthcare system is. But I'd love to hear about some real-world cases that you've had that you've used some of these principles with.
Absolutely. So I once had this 80-year-old female with coronary artery disease, vascular dementia, chronic back pain, and multiple falls. She was coming to us from her nursing facility with, yet again, another fall. Traumatic workup was negative. Her medication list showed us multiple CNS depressants, including both lorazepam and olanzapine. Deprescribing these could potentially improve her mobility and reduce her fall risk.
Whenever I see lorazepam on a patient's prescription list who's in their 80s, I definitely have concerns. I found a lot of times these are kind of legacy medications that were prescribed. The patient was taking them when they were in their 60s and it wasn't causing any problems. And then now they're in their 80s and they're used to it. They rely on it for sleep or anxiety or whatever they're taking it for. And it can be hard to get them off. Sometimes maybe the primary care physician just doesn't try to get them off, or other times maybe they try and the patient resists. But that lorazepam is always a red flag for me. So how would you approach deprescribing in this case?
So after identifying culprit medications, I look to see if the medication is clinically indicated and providing that patient some benefit. Fortunately, in this case, there are some guidelines that we can look to from deprescribing.org, a Canadian organization that provides guidance on how and when to deprescribe. They specifically have some guidelines on benzodiazepines. Within their guideline, they go through indications for which benzodiazepines are not indicated and may be a high-end target for deprescribing, versus other indications which are a little bit more complicated. Notably, that guideline states that lorazepam used for anxiety probably should be continued. It's very complicated in those cases and something that needs to be really worked through with a psychiatrist. However, this patient in particular was using the lorazepam to help with sleep at night. In some cases, older adults might use benzodiazepines for insomnia. However, it should never be longer than 6 months, and it should only be a minimal dose. And indeed, studies have shown that cognitive behavioral therapy is far more effective in treating chronic insomnia. When I asked this patient why she was on it, she told me she'd been on lorazepam for over 2 years and was using it to help with sleep at night. I pointed out to her that cognitive behavioral therapy might be a reasonable alternative, and it was likely that she could stop taking this medication.
That's interesting. I actually did not know that CBT helped with sleep. That's magical. So what about more complex cases? And I'm thinking about some of the ones that I struggle with are patients who are on, for example, multiple antihypertensives or cardiac medications, and they come in with those nonspecific symptoms, weak and dizzy or pre-syncope, lightheadedness. And those to me are tougher because maybe they need those medications. How would you address that?
That's a great question. Another case I had involved an 86-year-old male on multiple antihypertensives who presented with pre-syncope and orthostatic hypotension. This raises the question of whether to adjust his blood pressure medications. Interestingly, a recent UK trial, the Optimize trial, provides some guidance on this. Using a non-inferiority margin in a population of older adults 80 or older and on 2 or more antihypertensives with a systolic blood pressure of around 130s, they were able to successfully de-escalate antihypertensive therapy by removing a select agent at the PCP's preference. This trial got a lot of talk in the deprescribing world, in particular demonstrating the point that maybe non-inferiority or loss of clinical efficacy is sufficient to justify the act of deprescribing. In this particular case, we have a orthostatic event or pre-syncope related to possible cardiac medications, further justifying the act of deprescribing. Regardless, that trial did rely on the primary care physicians to appropriately choose which agent to de-escalate, thus demonstrating that this isn't necessarily an act in which I'm telling the patient which specific medication to stop, but I'm redirecting them to their PCP with specific guidance on, I need you to discuss the use of this medication with your primary care physician in the next couple weeks.
Yeah, that's a great example. And that's usually my practice, is to talk with them and say, hey, looks like you're on 4 different medications for your blood pressure. It might be that now, just with your changes in physiology, change in age, that it might be helpful to stop one of them. Can you talk to your doctor about this? Or I'll send a message if their doctor is in our system, and I can message them to say, hey, this patient came to the ED with pre-syncope. I'm wondering if it could be an effect of the polypharmacy. Could you help make some decisions? I know you've also done a lot of work on aspirin and bleeding risk. What is the guidance, or are there any guidelines that we can use for how to reduce risk of bleeding in older patients?
Yeah, this is particularly of interest for me. I've done a lot of work here since the USPSTF guidelines have changed on aspirin, in particular primary prevention aspirin. This was recently added to the newest iteration of the Beers criteria, stating that primary prevention aspirin can be a target for deprescribing.
And is that the baby aspirin, the 81 milligrams, or 325, or both?
It's both. And it's anyone using aspirin in the absence of identifiable cardiovascular disease.
Got it.
So this would be a patient without coronary artery disease, prior stroke, or any vascular disease. But let me take you to a case that I recently had about this. I recently had a 68-year-old female with a history of DVT and PE on apixaban, hypertension, hyperlipidemia, uterine cancer post-hysterectomy, and lung cancer with bone mets. She came to us again with a fall. We found a sacral fracture, but ultimately were able to sort of discharge her. Her medication list revealed she was both on apixaban and aspirin.
And how concerning is that combination of apixaban and aspirin? How much does that increase your risk of bleeding as opposed to just the apixaban?
This is the kind of case that makes me want to pull my hair out. There are studies showing that this doubles to quadruples your risk of bleeding. One, there's a very clear drug-drug interaction in this case between apixaban and aspirin. But also, she doesn't have any history of cardiovascular disease. No CAD, no prior stroke, no vascular disease when I really drilled down to it. When I asked her about this, why she was taking aspirin, she said she just took it because her sister takes it. She's just buying it over the counter. So this was a very easy case of deprescribing. There actually is some real studies, some pharmacoepi studies that are showing it usually happens mostly in patients with AFib rather than patients with VTE. But there's a lot of patients who have AFib on an anticoagulant who for some reason then go ahead and choose to use primary prevention aspirin. This is very dangerous, and this is I wouldn't even classify this as potentially inappropriate aspirin. This is inappropriate aspirin and a clear reason to discontinue a drug.
One of the challenges of deprescribing is in order to deprescribe or change or reduce the dose, you need an accurate list of what is the patient even taking. And sometimes there's the list that's in the EMR, there's the list that the patient tells you, there's a list that the patient has on a piece of paper. But to really get an accurate list, you kind of need somebody from pharmacy to come do a med rec. So is that something we need to have as part of deprescribing, or what's your take on that?
You're hitting me with all the hard questions. Medication reconciliation is critical, but it is very labor intensive. This is something that's very hard for an ED doctor who's running around dealing with the patient in septic shock and juggling 5 other patients all at once. I would say if you're a level 1 accredited geriatric ED, this is probably more routine for you guys to have geriatric pharmacists, something that's more available to you. You can work with them to help develop protocols for medication reconciliations. However, if you are not that level 1 geriatric ED, there are probably alternative roads you're going to have to consider. I don't think it's within our scope to really address every medication all the time. However, I do think it is imperative that we identify events in which an adverse drug event manifested or nearly manifested. In all these cases, such as like the aspirin and apixaban patient, that's a patient who fell. Fortunately, she didn't have a brain bleed, but that could have been a really disastrous event. It made me look a little bit more closely at those blood thinners.
What are the top 5, say, medications that should be considered for deprescribing? Because you said, well, we can't always do a thorough dig through of all the medications, which I agree. Are there some, in addition to aspirin for primary prevention, that might be an easy one to knock off? Are there others that, if they come up, our spidey sense should start to go up?
This is a tough question. I don't know that I have a perfect answer for this. In the deprescribing world, there's kind of a big divide between removing medications that are used in preventive care, like this is your aspirin or statin. Patients are usually pretty amenable to having these conversations. Statin's a really divisive issue, even though we do see patients with a lot of weakness related to it in the deprescribing world. I don't know that I have a real strong opinion. I think aspirin's probably up there, but I would be very careful. And if you are not comfortable identifying what is primary versus secondary prevention aspirin, this is always something that you can kick back to the primary care physician. The medications that tend to be more difficult for us, and I think patients have a hard time with, are medications that are used for symptoms. This would be your opioids, your benzodiazepines, your gabapentin, your pregabalin, all these medications that we know are causing all these harmful events, whether it's acute worsening of delirium or some sort of decreased mobility potentially leading to a fall, possibly related to worsening cognitive impairment. For all these medications in which they use for symptoms, you have to take it context to context. You're going to be limited by not knowing what other medications they've tried and failed, what might be the clinical indication. But I do think this idea of starting a taper or encouraging the patient to move towards dose reduction or trial of less harmful medications, like moving from opioids to Tylenol for pain control whenever it's possible, and making those nudges is highly encouraged. If you look back in the deprescribing literature, patients are not going to like when you try to take away medications that control symptoms, such as pain or anxiety. So just be ready to meet a patient where they're at. You don't have much control if they have a prescriber that's giving this medication to them on a routine basis. Sometimes I think of this almost as a parallel to addiction care. I might not be able to make a real change in that person's care today, but I might be able to increase their awareness of the problems that are manifesting in their life from these medications. And in that, they may actually be motivated towards some sort of behavioral change down the line.
That's a really good insight, that there really isn't any sort of automatic, well, if you're on an aspirin, you obviously shouldn't be, because it depends on the patient, depends on the context. If you're on lorazepam, you shouldn't be. Well, it depends, again, on the patient. Maybe you're taking it for alcohol withdrawal, in which case you should be on it, at least for a short while. And this is one of the big challenges in geriatric EM care, is there isn't a cookie cutter algorithm for these types of things, and it depends on the patient's symptoms. Maybe they really need that opioid for their pain, or maybe they need that gabapentin for their neuropathy. Before we wrap up, any closing thoughts or tips for listeners?
I think there are some really wonderful resources out there. Feel free to go check out deprescribing.org. That's the Canadian-based organization that writes some guidelines around this. I also participate in the U.S. Deprescribing Research Network. They have their website at deprescribingresearch.org. I think there's a lot of wonderful resources about how to educate your patients at the point of care and encourage them towards removing potentially harmful medications.
And I think this will become all the more important and hopefully get a lot more people talking about it now with the new age-friendly hospital measures. If at every hospital admission or before every procedure, the medications have to be reviewed for potentially inappropriate medications, then hopefully we can start to get a little more guidance on what are the potentially inappropriate medications in a given context for a given patient. How do we make that determination to then decide whether to reduce the dose or discontinue them? So thank you, Dr. Casey, for sharing your expertise on this really crucial and underappreciated topic.
Thank you, Dr. Shenvi. It was a pleasure to discuss deprescribing with you.
That's it for today. Stay tuned for future episodes. We will be talking more about the age-friendly hospital measures, as well as lots of other topics related to geriatric EM. Thank you for listening to this episode of GEMcast. You can connect with me on Twitter with the handle @GEMPodcast. You can also navigate over to gedcollaborative.com for more resources on the care of older patients.